Good afternoon, everyone. My name is Kristen Rigo, and I am the Director of Health Transformation at the Association of State and Territorial Health Officials. I would like to welcome you to today's webinar on Community Health Worker Certification and Licensure. Integrating CHWs into the healthcare workforce is a growing strategy for increasing access and improving population health while decreasing costs. Today's webinar is the first webinar in our Community Health Worker Call series that is supported by the Health Resources and Services Administration. The objectives for today's webinar are to describe the current landscape of CHW certification and training across the country, to identify common content and methodology that can be included when developing CHW certification programs, and to describe the opportunities, challenges, and barriers associated with establishing certification for CHWs. We have an esteemed panel of experts that will be speaking with you today. Following my introductions, we will have two presentations followed by an interactive panel discussion with our experts. If you have a question, you are welcome to post it in the chat box on your screen at any time during the webinar. These questions will be used during the Q&A after today's presentation. At the conclusion of the webinar, you will be directed to an evaluation survey. Please take a few minutes to inform us about the work you are doing related to community health workers and to provide us with feedback on today's webinar. We look forward to hearing about your efforts. Now I would like to introduce today's speakers, KT Kramer and Carl Rush. KT Kramer is the Director of State Health Policy at ASTHO, where she supports a peer network of state legislative liaisons and tracks and analyzes public health legislation, regulation, and executive orders across the states and territories. Prior to joining ASTHO, KT worked as a Winston Health Policy Fellow at the Senate Health Committee. Carl Rush has worked full-time for and with CHWs for the past 19 years. He serves as a core team member of a policy center on CHWs at the University of Texas Houston School of Public Health and has supported studies on CHW employment policy for the states of Arizona, Texas, and Indiana, and for public health, Seattle-King County. And our panelists today are Gail Hirsch, Katie Miller, and Sergio Matos. Gail Hirsch is the co-director of the Office of Community Health Workers at the Massachusetts Department of Public Health. As a longtime leader in CHW organizing efforts in the state, she has served as an advisor to other states, federal agencies, and national organizations on CHW workforce development. Katie Mitchell is a project director of the Michigan Community Health Worker Alliance. The Michigan Community Health Worker Alliance is a partner-driven coalition whose mission is to promote and sustain the integration of CHWs into Michigan's Health and Human Services system. Sergio Matos is the co-founder and executive director of the Community Health Worker Network of New York City. The network is a professional association of CHWs with over 700 members that works to advance the CHW workforce while preserving its integrity. And with that, I will now turn it over to KT Kramer.
Thanks, Kristen, and welcome everybody to the webinar. As Kristen mentioned, I'm the Director of State Health Policy at ASTHO, and part of my role is to track emerging trends and issues. And one of the ones that we've been following closely is the sort of emergence of community health workers, CHWs, and the certification and training process that states and state health agencies and territorial health agencies are undertaking. My presentation is going to be short with hopefully more time for some of the panelists to discuss more of the issues on the ground as they saw these programs and processes unfold. So what you're seeing now is a map of the national landscape for community health worker training and certification standards. We've seen in the past couple of years, over 20 states have considered or enacted or created processes and frameworks for community health workers to hit certification standards and training. And they've done this in a variety of ways, and I think that's sort of an important thing to mention is that there's no uniform policy. I think as states have conversations with their stakeholders about what the role of a community health worker is in their particular system, you wind up with different results. But there are some sort of commonalities. What you see with the states that are in green are ones where the state legislature has taken a role in creating a statutory program for certification. But again, even, and I'll touch on it a little more later, even within these state laws and regulations, there is variation in sort of how broad definitions are and how much structure the law puts in versus regulation. Legislatures have also been active in states like Illinois and Maryland in creating advisory boards and task force or work groups to look at the issue of whether and how community health worker certification should take place in their states. This may be a precursor to legislative activity or to sort of allowing it to happen more organically at a level below legislation and regulation. The states that are in blue are states that have where the state health agency has taken a lead in creating community health worker certification standards in the sort of within the authority they already have in their health agencies. And then Minnesota has sort of a unique position in that they have gone to the Department of Health and Human Services and were able to get a waiver so that they could fund the community health workers through their Medicaid program. The two states that are in yellow are ones that's legislation that we're currently following. And so you have in Florida, so Florida has an existing third-party certification program that operates. And what the legislation would do is essentially codify that program. And then New Jersey, the bill that's pending in New Jersey would create an advisory board to look at certification standards, but interestingly also tying it to looking at financing and how do you fund the work of community health workers through Medicaid and through private insurance. So that's sort of where we are right now, and I think the panelists will be able to talk a lot more about what the different approaches might look like in a given state and what some of the benefits and drawbacks are as they move forward. The final slide in my presentation is one where we sort of broke down what the different state policies and programs contain. And I think the main takeaway that I would have from this slide is really to sort of reiterate that there's a lot of variety and a lot of flexibility in how different states sort of structure these training and certification programs. I think you can kind of see from the dots that in Massachusetts and New Mexico, the legislative process was a lot more structured through their laws and regulations than I think some of the states that maybe just have advisory bodies. But I'm very excited to hear the rest of the panelists kind of go through again how to approach the conversation and engage the stakeholders. So with that, I'll turn it over to Carl.
Thank you, KT. Hello, everybody, and I'm really delighted that you all could join us. I was asked by ASTHO to comment before we get to the, lost the screen there. Okay, was asked to comment briefly on a project called the CHW Core Consensus, or C3 project. And this is really an adjunct to the consideration of certification. But as KT was saying, that the states are highly varied in their approach to this. And part of the thinking behind the C3 project is that the deliberations in each state, regardless of who's leading it, should be informed by some common understanding of the pattern of the roles and skills that community health workers play in various states around the country. Next slide, please. And so the purpose is to develop contemporary recommendations around the country. Each state will take its own lead and follow its own best lights in terms of how to use it. But we're talking about core roles which often translate into a scope of practice and core skills that are required to perform those roles. There's also a very important notion here of some core qualities, and most of you have probably heard the term, the phrasing that a community health worker should be a member of the community whom they serve. That's kind of shorthand for a complicated set of issues mainly related to shared life experience. That part of the unique capabilities of the community health worker in working particularly in low-income communities and communities of color is that they relate to the members of those communities having lived through the same kinds of experiences that those community members have had. Next slide, please. I will add to that, by the way, in finishing that last thought, that roles and skills are relatively easy to define, and we're talking about definitions here, not so much regulation, but the core qualities are very challenging to embody in policy. So how those get handled, because they really are of the essence of the practice of the community health worker, how those core qualities get recognized in terms of making sure that the right people are hired for the work is a challenge in every state. So why are we doing this now? There was a seminal study published in 1998, National Community Health Advisor Study, which was the first real national look at these issues of, the common roles and skills of community health workers. And the findings of that study have been used in a number of states for the initial consideration of certification and also for the creation of educational programs for CHWs. But we have seen in the last, what is now 18 years, that times have changed and there's a lot more interest in the healthcare field in embedding community health workers in clinical organizations, and that is going to change the picture in terms of roles and skills. I think almost every state in the union now is at least investigating standards and potentially certification for CHWs, and so having some common basis for at least starting consideration in your state is, we think, a valuable thing. There has been some pressure from national organizations and even inquiries from federal agencies. Are there national standards for CHWs? I don't know that we'll ever actually get there, and states in general would prefer to reserve these decisions for the state level. But it is still not clear at this point how much states will agree with each other about such standards. And many of you have probably asked the question or have been asked the question, what is a good community health worker training program? There's no real way authoritatively to say what the answer to that is. Next slide. Another core value in this, and this has really been embodied in policy by the American Public Health Association. It's very important, regardless of who's leading the process or driving the process, that the process of defining community health workers, who they are and what they do, be led by community health workers themselves. This is something that almost goes without saying in other professions, and yet we've seen a pattern in many places of people feeling that they can speak for or make decisions for community health workers. So this is an important core value that we've tried to bring into the C3 project itself. Next slide. There was some precursor activity to C3, which was funded by the Amgen Foundation, in which one of the area health education centers in Texas solicited information on over 40 training programs around the country and has conducted an informal analysis of that. But in the next stage, some others of us became involved in it, that we started to take a look at a review of roles and competencies from 6 what we're calling benchmark states. And these are states where there's been a serious effort to align the training requirements for CHWs with the content of the job, the scope of practice. And so a crosswalk was performed between the scope of practice and skill requirements in those 6 states with the original findings from the National Community Health Advisor Study from 1998, and also the National Scope of Practice definition for community health representatives, which are part of a program for the Indian Health Service, and really the only national program of community health workers. That process has largely been completed, and this past summer and into the fall, some 20-odd state networks of community health workers were asked, and some local networks were asked to review and comment. Further modification was made to this kind of emerging consensus statement of roles and skills And the report from that process should be coming out in early April. It is now in the final editing and layout process. So that report will, of course, describe the process and give the final recommendations from 2015 about roles and skills, and will also include in an appendix all of the comments and dissenting opinions and concerns that were raised by the various reviewers up to this point. Next slide, please. So beginning in the middle of this year and for about a year to follow, we're going to be changing gear. There will be outreach to additional community health worker groups, but also a consensus building with other stakeholder groups. We've already established contact, for example, with the American Hospital Association, the American Nurses Association, and we'll be looking certainly for input from them, but eventually some form of endorsement in the sense that that organization representing its constituency believes that this statement of roles and skills is a fair depiction nationally of what community health workers should do. And so that outreach is obviously crucial, not only to further broadening the consensus, but even basic education of some constituency groups about understanding who community health workers are and what they do. Second major task, which has been an ongoing issue discussion for some years, now that more community health workers are working in clinical settings, is there a difference between the roles and the skill sets that community health workers require in that setting and those required for folks who work exclusively in a community setting? That, I think, is going to be a very rich conversation and will be helpful to folks in setting standards. As, for example, in New Mexico, where they have a core certification and then a level 1 specialization certification that they call clinical support skills. So that is optional. The third major task will be coming up with recommendations on methods of assessing proficiency in these skills. And we don't really have time at the moment to go into this, but it seems clear that many conventional methods of skill assessment through exams and that sort of thing are not appropriate to the skill set of community health workers. So something more like performance-based assessment, looking at actual measures and methods for assessing skills using such methods will be helpful both in an educational setting and in an employment setting for performance assessment. And also, since assessing those core qualities, that sense of community connectedness is so difficult to do with conventional means, it's important at least to provide tools to employers to find ways of assuring that they're in effect hiring the right people, that people have the right degree of connectedness and credibility and commitment to the community to make a good community health worker. Next slide, please. These are the states, I'm not going to go into detail on this, but these are the states that we looked at and the sources of information about scope of practice. We were not able from the Indian Health Service to get a national statement of core competencies. They're still working on that, but the various regions and tribal governments have their own standards for skills. And the states involved are at different stages in developing standards, certainly, but these are all states in which they've given a very serious look at understanding the roles and skills of the community health worker and the congruence between the skills and the roles that they serve. Next slide, please. We're going to make available through ASTHO a number of resource documents. Obviously, the publication from 2015, the publication of the 2015 recommendations from C3, but also a number of the other very relevant source documents This is not necessarily a complete list, but there is also, should be in 2017, a national policy study sponsored by CDC on certification. That study is not going to begin until probably July this year, but that will be also very valuable, we think, to the states. Next slide, please. So you will be able to download this information when the slide deck from this webinar is published. But for more information, you can send us an email, and there's also a link to join our mailing list. Next slide, please. So in transition to our panel, I wanted to just go over some basics about certification. This is really not about regulation of an occupation, and we need to make that clear at the outset. But certification in general, the sort of dictionary definition, has to do with some issuing authority declaring that the individual has certain qualifications. It may or may not, but it's generally not the same as an educational certificate of completion. Some states may choose to make that equivalent. That's really up to you. But it is important, and we're seeing some examples of this already, that the issuing authority per se does not have to be the state government. It could be, again, an educational certificate issued by an association, or even an employer-based group issuing the certification. I also want to say that licensing at this point is probably off the table. Even though that's part of the title of the webinar, we need to say that what we're looking at here is not prohibiting what people do, because there are an awful lot of volunteers doing this kind of work now, have been for decades. And there's no particular issue of potential harm to the public if the scope of practice of the CHW is properly understood. And the CHW is, first and foremost, not a provider of clinical care. And so the issues of licensing, in several states, they've explicitly said, we're not going to license these folks. It's not appropriate for our licensing authority. Next slide, please. And then lastly, there are folks who have misgivings about certification. There are many pitfalls that can happen along the way, but what we're seeing from the pattern of mistakes made in the early states and the reservations that people have, certification in general, there should be multiple paths for entry, including based on experience. The process should be user-friendly without unnecessary barriers. And in the state of Texas, we don't have any of these requirements as part of certification. If there is going to be education required, it needs to be in familiar, accessible settings using appropriate methods. And we have one of our panelists today, one of the national experts on popular education for CHWs, Sergio Matos. It is about the congruence of the educational methods to the skills and the characteristics of the candidates for this work that specify that these methods are appropriate. If you're going to have continuing education requirements, then there needs to be adequate access to those opportunities. And in many cases, especially with rural populations, that distance learning is going to need to be an option. And then lastly, I would say we have tens of thousands probably of volunteer CHWs around the country. And the last thing we want to do is impede them in their work. So as you're considering the issue of certification, remember the dictum of the medical profession, which is first do no harm. We don't want to do anything to impede volunteer CHWs in their honorable and very successful work. So with that, we're going to turn to our panel, and I'm going to pose a series of questions, and we're going to ask each of the panelists to respond to this one question at a time. And we've randomized the order of their responses. So you won't always be hearing from the same person first on each question. So, beg your pardon with the cough here. So the first question is, what process was followed in considering certification in your state? And by that, we're saying in part, who or what has been driving the process up to this point, and what stakeholders or other factors seem to be most influential in the outcome thus far. So if we can go to the next slide, please. We'll start with our first responder from Gail Hirsch.
Hi. Hello, everyone. You can advance to the next slide if you would. So in Massachusetts, to answer this question, I would say that this has grown out of a long-term partnership between the Mass Association of Community Health Workers, the Department of Public Health, the Massachusetts Public Health Association, and CHW training programs. This has been going on for close to 20 years as far as moving from being against certification towards supporting certification. The development of this partnership happened through the late 90s and early 2000s in synergy with some national efforts to define and study the workforce. And I would say it's been a process of convening key partners, building consensus. There have been multiple legislative and advocacy initiatives, and then collaborative implementation of laws that have been passed. There has been a dedication of resources to support community health worker leadership and engagement along the way. And the next slide, please. So brief overview, there was a statewide advisory council that grew out of our health reform law that wound up recommending certification amongst its 34 recommendations, which actually set the stage for MACHWA, which again is the Mass Association of Community Health Workers, to draft and advocate for rapid passage of Chapter 322 in 2010. That established the Board of Certification at the Department of Public Health. There was a decision made at that point that the state would be the issuing authority. And we went back and forth on this a lot. As Carl mentioned, this is a very important decision, and we don't know really how this is going to go. We know how it's gone so far. I would just sort of overlay all my comments by saying this is an experiment, and we are doing an evaluation, which is really important. We decided to house this at the Department of Public Health because it had capacity. And also we thought that it would give credibility to the certification. The board is comprised of strong CHW representation. It's a voluntary certification. It's a Title Act, not a practice act, and that means in order to call yourself a certified community health worker, you need to go through the process, but you do not need it in order to practice as a community health worker. And also the law requires the board to set standards for core training programs. And that's, thank you.
Okay, next slide, please.
Good afternoon. This is Katie Mitchell with the Michigan Community Health Worker Alliance, and I'm going to share a little bit about our process in Michigan. So MISHWA was founded in 2011, and we have been in process in kind of tackling this question of certification since our founding. It was identified really early on as an essential discussion item, and that very much fit under our mission of promoting and sustaining the workforce of CHWs. And so since 2011, we've had significant discussions with stakeholders and other groups of CHWs, employers, and others, even broader, to really tackle this question of what does certification mean. The way that MISHWA is structured is that we have working groups, a steering committee, and we also host a lot of conferences and events to bring others in to make sure that we're being as collaborative as possible in this process. We spent a good part of 2012 doing a lot of research. We hosted some CHW-only discussion forums at the beginning of 2013 where we presented a lot of that research and provided CHWs an opportunity to really get together with each other and hash out different thoughts and opinions and feelings about all of that work that had been done. We issued a policy brief in 2013 indicating our support for a certification system, keeping in mind that for our purposes, as Carl discussed, certification is voluntary. It's not something that would be mandated. It would be an option. And then we continued our journey into this by doing more research. A big part of it is that with certification, there's a lot of elements. And so Gail alluded to many of them and kind of the process in Massachusetts. And we're still tackling a lot of those in Michigan. So when you think about what goes into certification, that includes things like time frames and standards and curricula and all of that. And so we've spent the last couple of years doing additional research. We've also looked at the processes in other states as well as for other professions to find good models. And at the end of 2014 determined that MSHWA would manage the certification process versus a different type of authority such as a state government. And in 2015, we were able to take all of this information back to our larger stakeholder groups, including CHWs, health plans, health systems, employers, and gather additional support. We've also used a lot of tools to support this discussion. These are two pictures from some of our forums in 2013 with our CHWs. We've done a lot of this work over conference call. We've done surveys. We had a statewide survey in 2014 that assisted. We do a lot of polling. We're doing polling right now actually on the grandparenting provisions as part of certification. And the process is iterative and ongoing. And so it takes a lot to engage various types of stakeholders and a lot to educate. And so we really focus on making sure that at all times we're engaging people and making sure that people are aware of what's happening. Some of the challenges to the process, though, are making sure that all those people are included and that all of those voices are respected. And so that's part of our core principles is to really make sure that collaboration is participatory. And so we really do work hard at making sure that all voices are brought in as much as possible. It also takes a lot in terms of challenges to get people up to speed on what decisions are being considered and why. And so even getting overviews on a webinar like this can be really helpful in moving the process forward by getting an overview of what some of the options are and considering some of those what ifs. What if certification was in place? What if there are volunteers? Things like that. We also are still in process of getting caught up in all the details versus the big picture. And that's something that's very common, thinking about the bigger kind of reality that would be created by certification. And sometimes those details can bog things down. And so really is a collaborative process. And in Michigan, we have really worked really hard to counter beliefs that stakeholders can only be reactive versus proactive. And that certification ultimately is something that community health workers really need to have the true kind of say on in the end, and that MSHWA can serve as a place to foster all of those voices and really support all the community health worker, employer, and other stakeholder voices throughout this process. And I'll turn it over from there to Sergio.
Thank you, Katie, and everyone. Welcome everyone to this webinar, and thank you for joining us. My name is Sergio Matos, and I am the co-founder and executive director of the Community Health Worker Network of New York City. You see before you on the slide there our mission. I give you a second to read that. Oh, it advanced. I just want to say that all of the comments that I make within the context of my position as a leader of a workforce and a professional association of that workforce. So the process that we followed started, I guess, about 7 years ago. And having worked for about 15 years to advance the CHW workforce, we knew that this was going to be a long, an extended effort. And so the very first thing we did was secure funding to support a small staff of people for what we anticipate would be a 2-year effort. We wanted to have a dedicated staff that would be able to work full-time on this effort for at least 2 years. The other big thing we did with our process is that we committed to a stakeholder-led process in which case, and I'll talk to you a little bit about that in a minute, and that whole state-led process be under CHW leadership, in agreement with a lot of the national policy positions that were emerging at the time, including APHA. The other big thing we did with our process is that we, from the very beginning, tried to secure, we secured academic partners. We sort of had a suspicion that this was going to take some original research, and we wanted to publish our results. We had a vision to be able to publish our results, and so we aligned some academic partners, and you see some of them here, but although there were 5 or 6 others. And then lastly, in determining our process, we thought it important to develop a leadership group, and we wanted that leadership group to be representative of pretty much all stakeholder sectors that had an interest in the CHW workforce. Secondarily, we sort of had a sense that at the end of the road we were going to have to change systems and policies, and so we wanted these leadership advisory group members to consist of really top leaders, thought leaders from across the state that might be capable, and if engaged, to be able to realize change down the road when we were able to make our recommendations. And we wanted to have statewide representation. Very similar to the way Gail and Katie expressed their efforts, we were very focused on supporting regional CHW organizing to participate in this statewide effort. And actually, in some cases, it took where we had to go to parts of the state and beat the bushes and sort of find people who were wanting to organize, CHWs who were wanting to organize, and then help them really develop local or regional networks of CHWs to support our statewide efforts. And then we did support CHWs to participate and lead this effort throughout the entire period. Next slide, please. The other thing about our process is that once we convened our leadership advisory group, and it was about 60 people, and remember, these were all top leaders of their sectors. So, for example, when we sought out regulators, we didn't go to every elected official in our chambers of Congress, but rather we went to the chairs of the health committees in those chambers. When we were looking for hospital representatives, we didn't go to every executive director of every hospital, but to the executive director of the statewide association of hospitals. And we followed that approach in all the sectors. So anyway, we established that leadership advisory group, and they very early decided that their priority was going to be financing, because their goal was to sustain the CHW practice, and so they very quickly focused on financing. However, they realized that in order to consider financing, they needed to have some kind of training or credentialing thoughts in mind so that they would know what they were paying for. And then in order to have training or credentialing processes in mind, they realized they had to have a scope of practice to figure out what it was they were training and credentialing. And so they established these 3 working groups to do that work. Each working group was co-chaired by a CHW and a stakeholder. The work group efforts were staggered because the leadership advisory group also quickly realized that they needed the work of the scope of practice work group in order to do their own work. So the scope of practice work was done at a quicker pace and before the other 2 work groups really started their work. The very first thing that the scope of practice told us was that they needed some rigorous market analysis to be done in order for them to understand what were the CHW's scope of practice, including roles. We had to go out through our academic partners and actually conduct that rigorous and original scientific research and the enormous data analysis that was associated with that. So it was lucky that we had established these academic partners beforehand, anticipating that we might have that need. The academic partners did all of that work. They, through the CHW network, conducted a lot of CBPR surveys. I think we interviewed a couple of hundred CHWs and almost 100 employers, payers, regulators, and labor representatives. Next slide, please. So the results of if I fast forward 2 years, the results of our work were, and this was a statewide CHW effort, is that we adopted the American Public Health Association and our own CHW definition, which is published and we'd be happy to share with you. We established a statewide evidence-based CHW scope of practice, and again, that's on our website, which was on my introductory slide. That scope of practice articulates the CHW roles, the CHW task, and the CHW skills that all significant stakeholder sectors look for. We analyzed the results of that rigorous scientific research using a number of analytical methodologies, and they were done through our academic partners. And then at the suggestion of Carl, who was one of our national leaders on our advisory leadership advisory group, we applied a labor functional task analysis, which really is it's a very rigorous analysis of data. There were two very interesting things that emerged out of the findings that we did not expect, in spite of our extended experience in advancing the workforce. One was that employers of CHWs identified a number of priorities that they utilize in assessing and hiring CHWs. And you see those listed. They include shared life experience, a recognized set of personal attributes that Carl referred to, but these are personal qualities. These are like, personal attributes that employers very specifically look for in employing CHWs, and that makes this workforce a little different from others and has ramifications when you consider certification, because these are really not things that can be certified, but yet they're very critically important to employers. Employers always also look for previous employment as a CHW. And then lastly, and actually, ironically, least importantly, employers look for previous training. But many employers reported to us that previous training often gets in the way, actually, and they have to retrain CHWs to not implement a lot of the stuff that they come with from previous training. And most importantly, we found that actually credentialing, employers didn't care that much about it. It did not influence their decision of whether or not to employ somebody, and it just was not a primary element in their considerations. Next slide, please. And lastly, I want to say that the statewide efforts that we made to advance the CHW workforce, also besides the scope of work, once we had that established, the other two work groups were able to get to work. And the training and credentialing group published a set of recommendations. The most important thing that this group of leaders decided was to put certification considerations on hold. Primarily driven by the fact that there was an employer indifference about certification. And the group itself expressed the desire to be thoughtfully deliberate about this. And the other driving force behind this decision to put the brakes on this whole credentialing process was an examination of the national experience with CHW certification that was emerging, which was really providing more cautionary tales than best practices. A lot of the experience coming out of the states that were certifying was not really serving to advance the CHW workforce, although it was certainly regulating it. The training and credentialing work group also made very specific recommendations around training content and pedagogy, methodology, about the development of the training and how that should be done, and that CHWs be co-trainers. They made recommendations about citing and the delivery of the training. They made very specific recommendations about training institutions, requirements for those training institutions, and some thoughts around what might be a possible credentialing process. And then lastly, the financing recommendation, the financing work group made very specific recommendations to a variety of payers about how to go about funding for CHWs. I will say that New York, since the publication of these recommendations, New York has become a DSRIP state, and so these recommendations have been really integrated into the work of our Medicaid redesign team, and our district design teams. So I'll turn it back over to our moderator, Carl Harrison Rush.
Thank you, Sergio. Okay, great stuff about the process. Now, we have heard some things about reservations and in one of our presenters about initial opposition to certification, things like that. And so we decided to ask a little bit about, first of all, what are the pros, and in other words, the value. Who defines the value of certification? What's it based on? Who really initially introduced this kind of value proposition? Next slide, please. Katie.
Great. So in terms of kind of value, I'm going to talk a little bit about potential positive impact. And so just to start, I wanted to be transparent about what MSHWA's current recommendations are. And when I say that these are MSHWA's recommendations, it means that they have been approved by our steering committee, which is a body made up of community health workers as well as other individuals who formally apply to be a part of the committee and serve 2-year terms. And individuals represent various types of organizations all across the state. So in 2013, the recommendation came up from our working groups, both our Community Health Worker Network as well as our Education and Workforce Group, that Michigan should adopt a standardized competency-based training and certification system for community health workers, and that concurrently, Michigan should support policies for community health worker reimbursement through Medicaid managed care, and other payers. And so from there, we started embarking on our journey toward where we're at now, which is we have a standardized curriculum in place. We're actively training CHWs through it. We're looking to scale it in the next year so that it's accessible throughout the state versus in some kind of isolated geographic areas right now based on capacity. But from there, we also move to really getting more consensus over what that means. And when you talk about certification, the question of value really does come up. Is there value to it? Will someone pay a CHW more, or will there be more reimbursement opportunities for an employer because someone is certified or not? And so in 2015, MSHWA hosted a series of stakeholder forums, specifically with our payers to help address that question to an extent. And one of the action items from that would be that MSHWA should develop and implement standard steps for CHW certification in Michigan. And so some potential positives that we've identified over the course of time include the fact that right now the CHW role is still a little bit hazy. And so having something like a certification would really provide a lot of definition to the CHW's role. And that's not to say that a definition or a scope of practice or a listing of core roles and skills wouldn't do that as well. But we have moved toward certification because our CHWs have really called for that and have supported that. And this is one method through which a community health worker can be recognized. It's also an acknowledgement that a minimum standard of competency and skill has been met. And so to earn a certification, whether through training or through some type of grandparenting process, which we're still figuring out right now, it's kind of a stamp of approval that yes, we acknowledge that you have met this minimum standard of education and training within your profession as a community health worker. There's also an element of establishing the CHW profession as a profession versus a paraprofessional or unprofessional role. And that's still a battle that a lot of community health workers face, is making sure that in conversations about care, about working communities, that the CHW isn't ignored or thought of as this lesser professional because they don't have a license or because they don't provide direct clinical care. And certification is one method through which we can acknowledge or recognize the CHW as a professional. Not the only method, but one of them. And it's also validation of a CHW's investment in training and skill development. There's also impact for multiple stakeholders, which is a point I just really want to emphasize. There has been, in other places, there's been conversation about really what this value is to the CHW as well as to the employer. And so for the CHW, we hear a lot that there's a personal value. So from a CHW's perspective, there's a value in being able to say, I am certified. I've met this particular standard, or I would like to be certified so that I can say that I've met this particular standard. And then there's also professional value in acknowledging and validating where that particular person is in their professional career. There's also value to the employer in acknowledging that, yes, my individuals are certified, therefore they have met these particular standards. Again, in Michigan, this is not in place right now, but these are potential positive impacts that have been cited. There's also a lot of positive impacts that we're not quite sure about yet. So for the CHW, one of the most common questions that I get is, will my pay go up if I'm certified? And the answer is that we don't know. We don't know if a wage increase will follow. We also don't know whether or not we will have defined gateways to new education opportunities. The intent with our standardized curriculum, which we deliver in partnership with community colleges, is that at some point, because of our connection to the education system, there will be opportunities for that CHW to move through that system in another way if they would so like to. We also anticipate that there will be increased personal and professional efficacy for that CHW, that they will themselves will be empowered and feel like they have more agency over their profession and their activities. But again, that's a potential positive impact. There's a lot of CHWs right now. I am not one of them. I am not a CHW, but there are a lot of CHWs who are very, very confident in what they do and who they are as a community health worker. And certification may or may not increase that confidence or impact them in that way. We're not quite sure. For the employer, there's also potential opportunities for new funding streams, but we don't quite know what those are yet. There's a lot of educated guesses being made, as Sergio referenced, about whether or not a certified CHW would be eligible for reimbursement or not, whether it's through Medicaid or through other mechanisms, or whether or not health plans or others would acknowledge a certification as a minimum standard that they could get behind with some type of increased payment. We also anticipate that certification would create some type of workforce standard so that you could kind of more generalize kind of where people are and who they are and what they do, especially when you have so many people under different titles who have such varying roles within their different agencies that all fall under the CHW umbrella. And so this would be a way to really honor the diversity of the workforce, but still set a standard of competency or skill that people could align with in some way. And again, that's something that we anticipate, but is not guaranteed in any way. Sergio.
Are you on mute, Sergio?
I'm so sorry, I was on mute. So thank you, Katie. In considering the pros of certification, and in part of conducting our statewide CBPR work, original research, we actually asked people and groups of people, what is it that you are looking for in a credential? And many of the issues that were raised were the ones that Katie just itemized. The question of increased funding was usually central to most people's consideration of this issue, and in particular because so many community health worker programs are grant funded or were at the time. So people were concerned that people were wanting a certification to give them more funding availability and sustainability. But we're actually finding as a result that more recent developments in New York, especially with DSRIP, that it's actually the business case that is most effective to both CHWs and payers and healthcare administrators and designers. It's the evidence that exists for improved outcomes, cost savings, return on investment, and value added that is driving the funding of CHWs, not so much a certification. The other big thing that CHWs always told us is that they expect better opportunities and wages, similar to what Katie said. But in fact, employers don't care about that, so they're not asking for that certification. And so I don't know how much relativity there is to that. The other thing is that people thought that a certification would give them more prestige, recognition, and stability at their work, so they wouldn't get fired every 2 years when a grant runs out. But again, we don't know that there's any existing evidence for that. In fact, some of a lot of the recognition or prestige that might be associated with a credential depends very much on who the governing party is for that credential. There are some states where other professional associations have taken over governance of the CHWs and have actually created less prestige and less recognition. So that evidence is the jury's still out on that. And then lastly, there was a sense that a credential might provide increased cooperation with the healthcare community. But again, we have found that that doesn't depend so much on a credential, but really on understanding the role and the tasks and the skill set that CHWs bring. That's what makes them the most effective member of the evolving healthcare teams that are coming out of these new innovations. And when we find that when providers, particularly medical providers and employers, witness the success that CHWs bring, then that cooperation with those communities increases. Thank you. I'll take it. Gail?
Yes, yes, this is Gail, and I think Katie touched on a lot of what I was going to touch on. I would emphasize that we see this as a piece of advancing the field, not everything. I would just add that from various perspectives here, what some of the potential benefits that were anticipated might be. I would say that for community health workers, they see it as an opportunity to better define the practice. That is, to create awareness of and clarity around the scope and the skills, the competencies, and to build professional identity. And I'll just add to that right now that I think what we have found here in Massachusetts is that when we have some kind of legislatively mandated process that's underway, it kind of gently encourages people to participate in it, or forces people to participate in it, as it were. It actually sort of makes people pay attention to community health workers and to create consensus around it and buy-in and ownership of advancing the field. So I would say that every legislative process we've had has built consensus and grown professional identity within Massachusetts. Other things is the things that Katie mentioned around increased pay, benefits, supervision, training, and career ladders. We don't know if that will play out yet, but it's certainly, we're hopeful that it might. We had, from providers and employers, we actually did have a support for moving ahead with certification to help them understand what a community health worker does compared to other workforces, and to establish what the training standards would be for that workforce. And for us as well in Massachusetts, with our public and private insurers, we really actually found that we weren't able to kind of move forward with our without thinking about certification. So what we've tried to do from that perspective is create a process that would be led by community health workers. That is, both our public and private insurers are paying much more attention to this, are engaged in it, including our Medicaid agency, because we're actually talking about defining what the qualities and qualifications are of the workforce. So I think we can move on to the next question.
Great, thank you. The final question, as you might imagine, a little symmetry here. The cons or potential negative impacts. And it's inevitable that there would be pushback, skepticism, even resistance. But in your experience, when in the process were these negatives first articulated, and how influential do you see them having been on the outcome in your state? Next slide, please. Sergio? You're on mute again.
Thank you, Carl. So as you can probably imagine, I'm more in this camp than in the previous camp. and I've arrived there over many years of experience. So the concerns that people have raised around certification and the responses that I get from people and that we got from people when we were doing our statewide research were, and some of the evidence that's emerging from the experience of other states is that primarily certification could redefine the practice, and in fact redefine it to the extent that it would no longer even be recognizable. There might be a loss of identity, and specifically the power of CHWs to determine their own practice. And this has actually already happened in a number of states. We talk about self-determination as sort of the silver bullet to try to address this whole issue of redefining the practice. But in fact, some I know one state turned governance of CHWs over to a different profession, and now that different profession has imposed their culture and standards and norms on the CHW practice to where they're not even really recognizable anymore. So there is that danger. The other thing is that a certification tends to establish restrictions on a practice, so that there is a potential that the scope of work could become limited, especially if it's not informed by the evidence base. And there are other requirements generally for a certification which would have to be addressed, like educational, academic, higher education requirements that might not be relevant. Immigration status in some states might be an issue. And typically, I just finished publishing a book on how immigrants improve the health of how CHWs improve the health of immigrant communities, and those CHWs are generally immigrants, and so immigration status might be an issue. English-only states might have an issue with this, establishing a credential, and of course financial responsibility for the training and credentialing might be a burden. The other big thing is these criminal background checks, or like I said, employers look for CHWs because of their shared life experience. Well, if you're looking for somebody to work with teenage prostitutes, then you're going to want to probably find somebody who was a teenage prostitute, and that person might very well have a criminal record. And so people's criminal history might interfere with a credentialing process that uses that as a block. The other big thing is that it might not be necessary. People in our process said there's really no need for it. Nobody's asking for it. The business case for CHW effectiveness is extensive and convincing, and employers are really looking for personal qualities, not a credential. And so people are asking, well, and actually one of the participants on this very webinar posted a question about that, and I hope we get to address that. And then the big thing is that from the national experience, certification alone is not showing to provide any of those things that people are searching for in a credential. The other big warning point that and this came from our business community in our leadership advisory group, is that if you pass a bill that requires something, then that bill has to be funded. So, any credentialing process that any state decides to embark upon, there is some expense associated with it. Somebody's going to have to maintain, testing and evaluation. Somebody's going to have to maintain a registry of certified people and keep that current. Somebody is going to have to enforce that credentialing or regulation, and that's going to cost monies. And in general, the political climate across most states is that people are not looking to expand government or increase spending right now. So taking a legislative agenda or establishing a process that's going to require investment isn't really very attractive to many states. So I will turn it over to Katie, I guess. Oh, no, Gail.
Yeah, it's actually Gail. So, and definitely what you said was true, that your last point about the challenges of state government spending money on the certification process. So that's a fine tightrope we're walking here as well. Just to get into some of the challenges that we talk about inherent in certification, we acknowledge that it means different things to everybody, actually. Probably of the hundreds of people on this call, something different comes to their mind about what certification really is. And it can be different, and it can be shaped differently and designed differently. So that's really sort of the main take-home here, is that if it's done well, at least you have a better chance of having it be responsive to the needs of the workforce. Obviously, some of the potential adverse impacts, which were already mentioned, is that we do not want to erect barriers to entering the workforce or to practicing for effective community health workers that already are practicing. We don't want to diminish effectiveness of community health workers by distorting the identity of community health workers or over-medicalizing the practice. And we don't want to restrict community health workers because they're very creative and respond to complex needs. The other thing we also want to be careful about is creating separate classes of community health workers, that is, those who are certified and those who are not, and that is tricky. Moving forward, let's see, here's the next one. No. Can somebody advance it to the next slide, please? There we go. Okay, so thank you. So some of the ways that we're addressing the anticipated challenges is we're including a grandparenting provision that recognizes work experience. It recognizes voluntary and part-time work experience. There will be flexible training program approval standards. That is, the curriculum needs to be based on adult learning principles, but it is not going to be proscribed. The training programs will just need to address the core competencies. We're creating a user-friendly application. There are no minimum educational requirements. We will not be requiring proficiency in English. There will not be a test, but we'll be doing along the lines of what Carl said, some kind of performance competency-based assessment, and the fee will be affordable. Can somebody move it to the next one? Thank you. Lastly, we will be, or almost lastly, some of the things that we're doing sort of on a broader level to address some of these challenges are to engage people at every step of the way and create ownership. Somebody asked the question about actively supporting CHW leadership with resources. I can try to get into more detail about that, but in essence, the State Public Health Department is providing resources, financial resources, and technical support for the CHW Association to be engaging community health workers at every step of the way. The whole time we are going through this, we're recognizing the inherent tension of this work of formalizing a CHW profession while retaining and supporting the grassroots nature of the profession. And then lastly, what we're always careful to do is to include community health workers who work in community-based settings as well, not only in healthcare, so that this doesn't become a healthcare-driven process, that we're really recognizing the broad spectrum of community health workers that are working out there in the field now and who want to enter the field. And I think we can move on.
Great. So I'm going to finish up here real fast so we have time for some Q&A. But one of the big things that has been touched on already is just in terms of negative impact. The CHW role really has historically been grassroots, community-based, oftentimes an opportunity for entry into the workforce, many times for the first time, and really centered around this concept of life experience and or unique connection to community. And there's always concern as to what certification may do for that. And what's been really interesting is that as we kind of tackle the question about whether or not certification dilutes the workforce by ignoring some of those things, or whether it actually supports those, is that in Michigan our conversations look different. So some days it's that CHWs have this concern, and other days it's that employers have this concern. Because there is a perception that when you have someone who is truly grassroots of the community, community-based, that person getting a certification somehow is not that anymore. And so that's a tension that we're actively battling all the time and really trying to talk through and get different people's perspectives. As a disclaimer, as I've already stated, Michigan really is pursuing this because our CHWs and our employer stakeholders have supported it. But some of the potential negatives otherwise that have been recorded during this process include the cost of regulation and oversight, as well as decision-making over the course of time. And these have all already been touched on, but potential exclusion of CHWs, as well as cost to the employer, if the employer is unwilling to pay, or if the community health worker is a volunteer. And so in terms of handling it, how do we handle these potential negatives? We talk a lot. This is something very, very common for us. We discuss pros and cons in conference calls and in-person discussions. We make sure that whoever is on those calls is up to date as to what's going on. And it's a huge challenge sometimes. We really are built on participatory principles, meaning that we really value all voices. We make decisions by consensus, not voting. So we don't take individual tallies, but we don't move forward unless we're really all on board, or we're enough on board that we feel comfortable taking the next step forward. Next slide. And so some additional concerns cited by CHW's employers have led us to pursue various aspects of certification over others. And so as a result, things that we're pursuing now include MSHWA managing certification versus an external party. MSHWA was identified as this potential third party versus someone else because we are the Community Health Worker Alliance, and we are not formally associated with a specific employer group or other association. But there was some general consensus that if MSHWA was over it, then community health worker voice would be maintained and really be sought out and acknowledged as a part of this whole process. We've also made sure to include a grandparenting provision, which we're talking through right now, the voluntary process, which is inherent as part of certification. We're also pursuing employer-paid certification when possible. We polled our employers and had fairly positive responses through all of this. And we're also launching a registry for community health workers that you can enroll in as a CHW regardless of your certification status. So there will be the method on the registry to identify who is certified and who is not, and that will be the method by which MSHWA certifies CHWs, but any CHW has the freedom to register, which we're also hoping will help reduce some barriers for CHWs who may feel in a different class than someone else, as Gail stated. So with that, we'll move on to Q&A. Carl.
Great, thank you. And I want to thank all of our panelists. A lot of important perspective here for our participants. And I'm going to ask Kristen to field or select the questions. Our main intent here is for the panel to be able to respond to questions from the participants. And we will be, since we're running a little low on time, we will make the commitment to ask the panelists to respond in writing to any of them that we're not able to handle verbally. So, Kristen, do you want to toss out a question we've received by the chat box?
Sure. So this first question will be for Gail. Could you speak more about the dedication of resources to support CHW leadership, and who from and how much?
So sure. So this is an almost 20-year process of ongoing support from the state for the Mass Association of Community Health Workers that somebody else actually asked about as well, around seeding the formation of it back in 2000. But more recently with the certification process, the Department of Public Health used small pockets of resources for MACHWA to convene town halls across Massachusetts to get community health worker input on certification before the decision was made to go forward, to work with the Code of Ethics and adapt that for Massachusetts, to hold educational forums across the state to help community health workers understand what certification what's happening with certification, and to gather input from them about the process, to bring them to certification board meetings and help them to have an organized voice at certification meetings, to also develop materials that are friendly and around application and around the process, and I'm sure there are other things too, but those were the quick things I jotted down in response to that question. But in essence, we do not move forward on anything here without significant community health worker input and also leadership around convening community health workers to gain leadership skills as well.
Mm-hmm.
Yeah.
Great, thanks, Gail.
Thank you.
So this next question is for Carl. Can you define provider clinical care further? And could you tell us more about non-clinical tasks or things that may require a license to practice?
Sure. Well, I think the first thing to say is that clinical licenses mean that someone who does not have a license, it's illegal for them to perform the tasks that licensed profession is allowed to perform. And one of the things we run into is that, particularly in healthcare organizations, is that folks have a hard time wrapping their heads around how someone can be effective in their organization without significant clinical training. And the point is that community health workers do not diagnose or treat or dispense medications. They do not perform lab tests and so forth. They may perform vital signs that an individual should be able to perform for himself or herself. Like it doesn't take a license to take your own blood pressure, that sort of thing. But those are about as far as a community health worker might go in providing clinical care. So that's anything involved in actually diagnosing or treating illness. There is sometimes some confusion between community health workers and direct care workers, like personal care attendants or home health aides. And these are very different skill sets because those individuals are providing direct services necessary for maintaining or improving the patient's health. The community health worker is much more in a mode of coaching, supporting, advocating for teaching, supporting adherence to treatment, things like that, helping people overcome barriers to keeping appointments. These are not things that require clinical training. And this can be very important for the organization in terms of improving communication, increasing levels of trust and relationship between provider and patient. These are all strengths that community health workers have that are not directly involved in the provision of clinical care. And lastly, one thing that has become extremely important is assisting with the management of social determinants of health, both by helping providers, clinical care providers, understand the life of the patient, but also helping the patient to deal with micro issues like housing or family violence, things like that, that clearly affect people's health, but they're not within the purview of the clinical provider, like a physician or nurse. So it's a very important distinction, and it's one of the reasons why it's not necessary for CHWs to be licensed. It's also not necessary for them to have professional liability or malpractice coverage because they are not conducting activities that are subject to those kind of standards.
Great, thank you. I think this next question is for Katie, but if others have anything to share, feel free to chime in after Katie. So for individuals who are now taking CHW training, whether online or in a classroom setting, will certification be available or an option for them? Is it available statewide or is it only available to MCHWs? And has it been decided or is it in discussion for now? Is it up to providers, employers to decide? A long question.
Yeah, so I can chime in a little bit on that, but I welcome the other panelists to also share. And so currently in Michigan, certification does not formally exist yet. So MCHW will launch our certification process later this year, but it's not up and running yet. So right now, options for community health worker training in Michigan include our core competency-based curriculum, which is being implemented across the state in various parts. And to date, we have over 75 CHWs who have completed, with several more in process. We also have a history of training in the state. And so there will be several dozen, if not 100, of CHWs who will be eligible for grandparenting. And we have not finalized those criteria yet, but there will be CHWs who have previous training experience, whether it be electronic or in person, as long as it hits on some of our core competencies. And as part of grandparenting, there will be a provision where the CHW will have to verify that they have met those core competencies, but we're still kind of figuring out the details of the extent to which an employer can sign off on that versus previous training experience documentation needing to be provided for that.
So this is Gail, and I'll jump in from Massachusetts. The way it will work here, we believe, it hasn't been finalized yet, is that any community health worker in Massachusetts can apply to become certified. If they're going through the training and work experience pathway, they will need to submit evidence that they have successfully completed an approved training program. Otherwise, if they go through the work experience pathway, they won't. All CHW applicants will need to submit 3 references attesting to their proficiency in the core competencies. So again, like Katie says, the devil's in the details there, how we're going to do that. But again, we're trying to adhere to the principles of not creating barriers to community health workers who are successfully working now. So I think that probably answers the question from our perspective.
Yeah, if I could just add very quickly, in New York, our recommendations really centered around credentialing training programs rather than credentialing individuals. And a number of reasons for that were that there were many members of our leadership advisory group that were either academic training institutions or proprietary training institutions. And this whole, in New York at least, these concepts of either credit for life experience or college-bearing training programs, college credit-bearing training programs are very, very complex issues. Evaluating life experience for credit is really, really difficult and complex, according to these, educational experts and institutions. And so, rather than put that onus on the individual, we chose to credential training programs that were responsive to the CHW scope of practice and that applied appropriate pedagogies.
Great, thank you. So this next question isn't directed towards any of our speakers, but maybe we can start with Carl, and then if other speakers want to chime in. Is there any realistic chance of moving beyond grant-based funding for CHWs, e.g. in integrated care teams without CHW certification in the context of changing payment models under ACA?
Sure. That's, I will say it's a very important question, maybe a little beyond the scope of this particular webinar. I'm hoping we'll get back to one later, but I will just say very briefly that, well, as Sarah just said, the financing question is not dependent on certification, certainly. That some agreement on qualifications is going to be important. There are a lot of different pathways to sustainable funding. Grant funding, by definition, is pretty much out of the question as a sustainable strategy. But I'll just say a couple of things. One, that, of course, we're talking mainly about Medicaid, since the major area of effectiveness of community health workers is with low-income populations, but that there are plenty of things in those states which have a managed care model, that health plans have a lot of latitude to do things with CHWs now with no additional authorization from the state. Secondly, that a lot of states are moving toward some form of value-based payment for health care, and that the opportunity to persuade them to integrate community health workers into those strategies can really make a lot of sense. And I think that's really where the strategies like that make the most sense, rather than pursuing dedicated funding streams for CHWs as a workforce.
Yeah, I would say that the answer to that question, at least from New York, is absolutely yes. CHWs are being built into DSRIP models and integrated into healthcare teams quite extensively across all of our DSRIP recipients. And some of these DSRIP models are really quite extensive. Some of them are even called medical villages. So yeah, CHWs are being integrated as part of those teams without credentialing.
Gail or Katie, want to weigh in on that? Okay. Thank you. I'm mindful of our time. We're about 5 minutes before our planned ending time, so maybe this next one may be the last question. It's up to you, Kristen, but it's looking that way.
Yeah, I think that sounds great, Carl. So this last question will be for Sergio and also for Gail, if you both have remarks. In terms of the CHW advisory boards, what were lessons learned, if any, in terms of maintaining self-determination and making sure the voice of CHWs was heard in the process?
You want to go with that, Gail?
Sure, and it sort of goes back to what I was saying before. I mean, I think that we have dedicated resources and staff time to actually ensuring that there be a community health worker association with voice at the table and with support to speak up. And I think people need to be mindful of that. They need to to understand what the specific sort of perhaps challenges are that community health workers face in participating in these conversations, and actually make active attempts to get past them so that community health workers feel ownership, and otherwise there's no point in doing this. So I guess I would just leave it at that.
Yeah, I would say that it was really labor intensive for us. We really had to go throughout the state and beat the bushes and find small groups of people that wanted to organize, and then really work to help them not only become organized, but to become literate and intelligent about the salient issues, so that people were able to really consider what are the potentials and consequences of certification, not just the myths or the hopes or the dreams, but what is the reality and what is the national experience to date. So they could, be, like I said, deliberately intelligent about it. That was not an easy thing to do, and it took us quite a bit of time traveling across the state doing that. But I will say that CHWs are typically not in a position of power in their work experience, and so bringing them to a table of leaders and asking them to contribute to that needs support. People. That's not a normal posture or position for them to be in, and so they really need a lot of encouragement and support in order to be able to contribute their wisdom to a discussion of a group in which there are power dynamics that are working against us. That's
great.
It.
Thank you. So,
Great. Well,
Kristen, you have some comments to make in wrap up?
Yeah, so thank you so much to our panelists and our speakers today for the engaging discussion. I just wanted to mention that we have a couple of slides here with different references and also resources that will be available to everyone when the slide deck is posted on ASTHO's webpage. But I just want to thank everyone for joining us today, and as mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. So please take a few minutes to complete our survey as it provides us with useful information for our future projects. It also has questions related to the work you are doing around community health workers in your state. So we really want to hear about the work that you're doing and how it may inform our future projects. I would like to thank HRSA for sponsoring this webinar, and I would also like to thank our speakers, K.T. Kramer, Carl Rush, Gail Hirsch, Katie Miller, and Sergio Matos. A recording of today's webinar will be available on our website within the next few days. and the web address is on your screen now. As Carl mentioned, we will also post the answers to some of the Q&A questions that we weren't able to get to during the discussion this afternoon. We hope that you will be able to use this webinar as a resource, and we'll share the link with others once it is available. Also, please visit ASTHO's website to access a number of CHW resources along with the other resources that our presenters shared with us today. Information about the next webinar in this Community Health Worker Call Series will be available soon. And if you have any questions about today's webinar, please feel free to contact me at krego@astho.org. Thank you so much and enjoy the rest of your day.